Hi, everyone. Thanks for joining our TCD Bubble Study webinar. I'm Ajay Zachariah with NovaSignal Medical Education Team. All right, so before we start, give you some context. We are doing a screening of right to left shunt, which is commonly PFO using transcranial Doppler. This is very important in the workup of cryptogenic stroke patients. As well known, PFO is common in 25% of the normal population. Many studies have shown that in the cryptogenic stroke population, it's as high as 43%. The current standard of care is transthoracic echocardiography bubble study. This has shown to be a sensitivity of about 45%, which is pretty low, but it's so widely available, which is why it's commonly done. Transcranial Doppler bubble study testing has shown a sensitivity of about 96% for right to left shunts, but it's very hard to do and very operator dependent, and hence it's not widely available. Transesophageal echocardiography is the gold standard because it allows visualization of the intraatrial septum and the PFO, but it is invasive in nature, so it's not commonly used as a screening study. So there are requirements for a right to left shunt or PFO test, regardless of modality you choose. The first requirement is microair bubbles or agitated saline have to be introduced into the patient's venous system. The second requirement is a Valsalva maneuver has to be performed by the patient if you're testing for a PFO. So why is the Valsalva maneuver or strain so important? Well, that's because the PFO is not a hole in the heart, but it's actually a flap-like opening that normally closes after birth. However, in patients who have PFO, this flap-like structure has not sealed. Now, this flap-like structure is commonly closed during normal respiration because the pressure in the left atrium is normally higher than the right atrium. So what a Valsalva strain does is it allows the pressure in the right atrium to temporarily go higher than the left atrium. So if the PFO is not sealed, it will open at the release of the Valsalva strain. So many patients who have significant PFOs are functionally closed during normal respiration. So the TCD or an echo study will be negative for the study during rest. However, these PFOs will only open after release of the Valsalva strain because the increased volume from the venous circulation will overload the right atrium, temporarily causing the increase in pressure in the right atrium. So if the PFO is not sealed, it will open up. So how do we measure an adequate Valsalva strain? Transcranial Doppler technology is actually the only technology where you can actually measure the adequacy of the Valsalva strain. Just in this waveforms we're seeing here of transcranial Doppler flow, during normal respiration, the waveforms have a steady velocity, which is the baseline. When the patient does a Valsalva, the velocities drop, and we do the Valsalva for about 10 seconds. And then after the release of the Valsalva, there's a slight hyperemic response with return of flow. And this shows that the Valsalva strain was adequate on transcranial Doppler. How do we grade this? How do we grade the right to left shunt on TCD? We use the Spencer scale. We use the Spencer scale to do this. We can also use the ICC scale. The Spencer scale is, of course, grade 1 through 5, with grade 0 being no bubbles and grade 1 being less than 10, grade 2 being less than 30. Sorry, the slides keep going forward. And grade 5 being greater than 300, where you have a spectral, you have complete filling of the spectral waveform. These multi-center study was done last year at these 6 different sites. And Dr. Mark Ruman presented this at the stroke conference in February of this year. And ultimately, the conclusions showed that robotic TCD was substantially more likely to diagnose right to left shunts compared to transthoracic echo bubble studies, with an absolute difference of about 43%. This is in line with previous studies done with TCD compared to transthoracic echo bubble study. This study also showed that robotic TCD detected significant shunts in about 3% or 3 times the rate of transthoracic bubble studies. It also showed that robotic TCD is safe to use by any healthcare professional, and you do not need somebody with high TCD skills to do this study. So ultimately, the conclusion was that robotic assisted TCD may allow providers to get the high sensitivity of transcranial Doppler to detect these right to left shunts or PFOs without the need of having highly experienced transcranial Doppler sonographers. Now we'll go to the live bubble study demonstration. Josh will be doing the exam. Josh Renz.
Hello. Great. So we'll go ahead and select the exam here. Select bubble studies. There's a few steps here. So we're preparing for the setup here. We chose the exam mode that we're going to use, which is bubble study. The first step here is to do a calibration of the robotics themselves, and then we'll go ahead and put on what we call the registration dots. So the tragus of the ear in the corner of the eye. We'll repeat that on both sides. These markers will give the robot the ability to search and find the window based off of where the zygomatic arch lies.
And now Josh will be adding the one requirement for ultrasound testing is gel in the temporal area of the window.
So cover the whole temporal window with the gel on both sides. Great.
And on the screen, you can see that it prompted him to do those steps, put the dots on, put the gel on. And the third step is aligning the patient in the robotic cradle.
Yeah, great.
Now, once he does that, he can click on the next screen. And the next screen prompts the operator to move the probe pods so that they touch the patient's head until the indicators are green, which means adequate pressure on the side of the patient's head. Now, once we see the dots are aligned, he can hit the start exam, and this is where the robot will automatically start searching for signals. You can see on the left side, it should find most of the MCA. And if the operator is satisfied with that signal, they can press hold on that one while it continues to search for the signal on the right side. So here Josh is preparing a syringe. You see he has 1 cc of air, do a little blood back, so you have a nice red bubbly situation. And when he starts injecting, he'll press the start button and start injecting. Arrest the injection, patient's breathing normally. And you saw one bubble there with Valsalva, so we would say the resting bubble steady with a small shunt, small right to left shunt. You can record for 1 minute because that's the protocol that is being used, the Spencer grading protocol, or Spencer right to left grading. And Josh will keep agitating the bubbles to keep them nice healthy, and now we're ready for Valsalva. So
1 second here, Richard.
Yeah. Valsalva, and
Go ahead and take that breath in, and then blow down. And 10, 9, 8, 7, 6, 5, 4, 3, 2, and relax.
So over here you're seeing quite a few bubbles even started before his end of his Valsalva strain. And that was a complete whiteout for at least 3 spectral waveforms. So that would be interpreted as a grade 5 right to left shunt with Valsalva. So after the 1 minute's over for Valsalva, we see there's no more bubbles coming across right after Valsalva release. Pause it or put it on hold or exit exam.
We'll exit the exam, and so we can review the study on the machine or via the cloud. On the cloud, we have the ability to look at all the images that were pushed from the exam. We will be able to replay this video and count each individual bubble. So as you can see, here in a few seconds, you'll see the shower of bubbles. In this case, since there were visually more than 300 bubbles, we don't have to actually count. So we can quickly and easily look after the exam on the cloud. And we can generate our report from here as well.
Well, thank you everyone for joining, and we'll hope to hear from you soon. Bye.